evening, everybody. It's my pleasure to participate in this conference again over these many years. My topic today will be novel approaches in atopic diseases, and I'll try to be very brief and precise. Before we go ahead to talk about new approaches in atopic diseases, I just want to talk a little bit about some of the immune stuff for you to understand, so you can understand how this medication will be working. First of all, how do you define atopy? It's a combination of three main illnesses or diseases: allergic rhinitis, allergic bronchial asthma, and atopic dermatitis. Just a little bit of immunology so you can understand how these medications work. First of all, we have, when we get exposed to any antigen causing the allergy process, the first thing we have is that it's exposure or being taken in by an antigen-presenting cell, or APRC in short. As a result, a material called interleukin, or a cytokine called interleukin-1 is produced. This in turn will attract T cells, usually of helper type 2. As a result, we have production of two main products, interleukin-4 cytokines, interleukin-4 and interleukin-5. In short, interleukin-4 goes ahead and directs the production of more IgE molecules, and interleukin-5 goes ahead into the clonal expansion of the eosinophils, the main allergy cells we have. As a result, we have specific IgE forms, and when we get cross-linking of these adjacent IgEs, we have sensitization to that material or that product. In short, as you can see here, we have our allergen or antigen. We have our antigen-presenting cells. You'll be seeing this slide a lot to be able to track with me the medication I'm talking about. We have attraction of the T cells, mainly helper type 2 cells. We have two main products produced, interleukin-4, interleukin-5. This goes ahead and causes more production of eosinophils, and this one goes ahead to the B cells, causing it to be producing more IgE cells. In short, the IgE binds to receptors. As a result, we have the release of inflammatory mediators causing the atopic disease or process. In any allergic reaction, we have two responses. We have the early response, which I just talked about, which occurs immediately, within seconds and minutes and so on. And we have a late response, which usually occurs 4 to 10 hours later, usually initiated by presence of other cytokines like eotaxins, rantis, and interleukin-8. Interleukin-4 goes ahead and binds to a molecule called VECAM, which is present, VECAM-1, which is present on the endothelial cells. And this VECAM-1 binds to interleukin VLA4 on eosinophils. So we have immediate release of histamine, tumor necrosis factor alpha, which is already present, just gets released, proteases, and heparin. Within minutes, we have lipid mediators, prostaglandins, leukotrienes, and as a late reaction, we have other cytokines produced, like more of interleukin-4 and interleukin-13. Usually, the initial ones, immediate release ones, cause sneezing, congestion, runny nose, itching, and watery eyes. The ones produced in a few minutes go ahead and cause wheezing, bronchoconstriction. Usually, the later ones, or late reaction, causes eosinophilic signs and symptoms, including mucus production. We have two types of immune cells. We have the naive CD positive cells. When they combine to this antigen-presenting cells, we have two pathways. One pathway is called Th1 in short, and the other pathway is called Th2. Th2 is what we call atopy. Th1, which directs the immune process towards delayed type hypersensitivity. Just take 2 points. The main two products of Th2 are interleukin-4, 5, and 13. whereby Th1 we have interferon gamma, interleukin 2, 3, and GM-CSF, and of course tumor necrosis factor beta, and cross-acting they both inhibit each other. So you have either a balance towards A2B, which is Th2, or towards delayed type hypersensitivity, which is Th1. Another hypothesis, we have one which is CD4 positive naive cells, whereby we have a cytotoxic TC1 and TC2. In short, I don't want to stay on that. TC2 goes ahead and causes eosinophilia and eosinophilic cell recruitment, whereby TC1 directs against to act against infections and neoplasia. Okay, first medication I'll be talking about is specific allergen immunotherapy. This has developed so much over the last few years especially, and now we have reached a point where it's being like a tablet. Usually we go ahead and use this for patients who have insufficient control by regular medication, or just the patient tells you, sorry, I don't want to be lifetime on medication, or is having side effects, or does not want long-term medication, as I said earlier. How it works is that we go ahead and reduce the specific IgE to that allergen. For example, in Jordan, we have most common seasonal one is olive pollen, whereby we have the most common perennial all year round allergen is the dust mite allergen. And as a result, by reducing the specific IgE, we reduce the signs and symptoms of allergy. Also, we have a formation of blocking IgG, usually subtype 4 and 2. As a result, it blocks the allergic process. In addition, we have something called T-cell energy, meaning we make these T cells non-reactive, inert. As a result, we don't have the allergic process going into cascade. And in addition, as I said earlier, we shift this allergic immune process from Th1 cells to Th2, from Th1 to from Th2 to Th1. As a result, we're going away from atopy and towards other diseases being atopic. Classically, since the 1920s and 30s, we had a subcutaneous immunotherapy. Early in this century, we started having sublingual immunotherapy, and just recently, the last 4 to 5 years, we have oral tablets. It's currently just approved for grass. Hopefully, next year will be approved for dust mite. It's available in Europe. I think it's just been approved to be used in Canada. I'm not sure about the States, but the FDA is delaying things as usual. When we're looking at atopic diseases, we always look at the patient as a whole and the cost. Of course, we have a patient education number 1, pharmacotherapy, allergen avoidance, and immunotherapy. So for WHO and other, let's say, allergy colleges and academies, we have long-term studies now talking about desensitization. And as you can see from these charts, this is a very long-term study over 12 years, have shown we have improvement in all patient aspects about its lifestyle, about the signs and symptoms, and clinical response. And even after you finish your initiated course of desensitization, it has to be shown to have long-term benefit, even up to 15 years so far. And we had meta-analysis of recently published from 1954 to 2018, being subcutaneous, sublingual, and the recent oral desensitization, which is for grass and dust mite currently, have shown clear evidence there's beneficial effects. Because when you go ahead and treat that patient to cure his allergic rhinitis, you also avoid other more mortal or fatal diseases like bronchial asthma, for example. Okay, next topic I'll be talking about is anti-IgE monoclonal antibody. The reason I'm talking about it, not just because of being used in allergic bronchial asthma, as it was initiated in 2007. Recently, we have a new indication for it, for the allergic or the urticaria and the chronic idiopathic urticaria. I've used it myself also for patients who had food allergy for so many years and have not been responding to any other type of therapy. I've also used it for patients who's been having also eosinophilic esophagitis, and it's been really working very well. I know these medications are off-label, but I want to share for you my experience. Since it is a pediatric setup, so I've used it from 6 years till 21 years for pediatric setup. I used it also for adults, but I've had like about 4 or 5 patients with food allergy been successful with. I've had at least 50 patients with some type of urticaria I've used it for, in addition to other subtypes. Okay, anti-IgE monoclonal antibody is omalizumab. It's a humanized monoclonal antibody. It binds only to the three IgE, and as a result, it downgrades these receptors which the IgE binds to. In addition, as a result, it decreases the amount of IgE present in the serum, and the result is that we are decreasing all the allergic process. I'll skip that. We talked about this. These receptors are for which the F is called FC epsilon R1. It's mostly available on mast cells, basophils, dendritic cells, and some other types of cells like the epithelial cells, the smooth muscles, eosinophils, and so on. If you just want a little bit immunology, this is our IgE molecule. I just want you to look here. This is the constant epsilon 3 area, and this is our FC receptor. We have 3 chains. We have the alpha chain, we have a beta chain, and we have a gamma chain. The alpha chain is the one responsible for binding to the IgE. So you get your specific IgE molecule binding to a specific receptor in this area between alpha 1, alpha 2, and C epsilon 3. The beta and the gamma chains are responsible for the transduction pathway to go ahead and let release of these mediators. This is just to show you the expression of these receptors is much higher in fatal asthmatics than in non-pulmonary deaths. It's around 4 folds. Just to make things brief, we have allergic process, we have release of IgE, and we have allergic mediators due to this IgE molecule binding to these receptors, causing the release of these mediators, causing the asthma exacerbation or allergic process. So what does omalizumab, as I said, it's a humanized monoclonal antibodies. It goes ahead and binds to this area so that this IgE molecule is not able to bind to its receptor. As a result, it takes it away, and in a very inert way, and being like 150 to 1,000 kilodalton, and takes it out of this patient's system. As a result, with no interactions of any kind of kidneys or liver problems or anything, and this is very safe. This is just follow-up studies to show you downgrading of IgE receptors in perennial allergic rhinitis patient. And this other graphs show you over time also the reduction of submucosal eosinophils in allergic asthma patients. And this one showing you the decrease in the sputum eosinophil counts in allergic asthmatics. And in addition, it doesn't just act in the early phase type, we also has shown to be effective also in the late phase effect in allergic patients. As a result, all these IgE molecules are taken away as a downgrading of these receptors, so we get at least a 40 to 60% reduction. As a result, less IgE, less receptors, less allergic process. And to be honest with you, I think it's much higher than that percentage, but from my clinical observation. Now I'll go ahead into the future. Right now, we don't have interleukin-4 inhibitory therapy approved for human, let's say for clinical use officially, but we have studies into stage 3, meaning just before the FDA lets it go into the market. It's been found that we have certain mutation interleukin-4 receptors. As a result, there is increased interleukin-4 signaling. As a result, it's giving signals to produce more IgE, more IgE, more IgE. As a result, we have more allergic process. Currently, we're working on soluble interleukin-4 receptors, anti-interleukin-4 monoclonal antibodies, and interleukin-4 receptor antagonists. So this has not made it clinically yet, but I think it will be just a matter of 2 or 3 years. It will be available as a medication. Next is the interleukin-5 based therapy. And we have already developed monoclonal antibodies, and it's maybe a few months when we have it in the market. And also, in the past, in the old days, we used to use gold salts and, of course, steroids for treating asthma, especially gold salts in the 50s and 60s. And the way it works is that it inhibits interleukin-5. Other medication to pipeline, we have tryptase inhibitors. We have phosphodiesterase 4 inhibitors. It has made it to be used in COPD recently in some inhalers in COPD patients. I think it will make it into allergic asthma patients shortly. Adhesion receptor inhibitors, we're still onto stage 1 and stage 2, meaning animal studies. And we have a chemokine inhibitor still. This is just basic research. It's not available for humans. The next subject I'll be talking about is atopic dermatitis. Classically, in atopic patients, we have increased IgA production, positive skin testing. I'm talking about allergic atopic dermatitis patients. And there is enhanced basophil histamine release, impaired type 4 hypersensitivity. So we have a shift towards Th2, decrease in CD4 cells, increase in CD23 on mononuclear cells, attracting more allergens and allergic process. Of course, we have increased interleukin-4, interleukin-5. We have decreased amount of interferon gamma, sorry. So we have an inhibitory effect, not that balance, it's all towards Th2. So when you take care of atopic dermatitis patient, you have 3 things to look at. From my part of view, you have immunological, environmental, and emotional triggers. Classically, the strategy we have been using is emollients, and then if you get into more inflammation, more severe, your only choice mainly was topical steroids. Of course, you may have to use systemic steroids in very severe flare-ups. So they went ahead, let's say in the last 10 years or so, they went and studied the T cells present in the epidermis itself. You can see here T cells present, and they were looking at the steroids they are using. It's damaging all these T cells, and as a result, damaging the Langerhans cells. So you're not having regeneration of skin to be healthy, and as a result, you have more disease and more severity. So we went ahead and developed the immune modulating agents, which were cell selective, attacking only the T cells, not like the classical corticosteroids being non-selective, damaging the Langerhans cells, the epidermis, causing all the side effects we know about in this medication. This is immunofluorescence showing you after treatment with immune modulating agent, bimecrolimus. And this is a solvent, meaning a placebo. And this is the treatment using, these are Langerhans cells, almost preserved with immune modulating agent, whereby with steroids, almost non-existent. Okay, just give me... Okay, let me go to the slide here. What happens in atopic dermatitis patients? We have our allergens going into the Langerhans cells. As a result, we have attraction of T cells. Okay, we have inflammation going on. This is what happens in atopic dermatitis. Go ahead and give immune modulating agents. It acts specifically on the T cells who are attracted to these Langerhans cells. It inhibits inflammation. If you use local steroids, it permeates into the skin, whereby there's a slide I skipped, but it shows you that immune modulating agent stays in the upper skin. Steroids go ahead, damage the T cells, then go ahead and damage your Langerhans cells, and go ahead damage your fibroblasts, so you lose your skin elasticity, you have skin atrophy, goes ahead into your blood system because it's going deep into the dermis. As a result, you get telangiectasia and all these systemic side effects. Just 2 patients using immune modulating agents. This bimecrolimus after 15 days, very severe atopic dermatitis in a very hard area in a child, in a 12-month-old. This is the result after 15 days. And the last slide, one of the toughest things to treat, facial atopic dermatitis. You can see this patient, and this patient after 6 weeks. And so it's been altered that now we can go ahead and use immune modulating agents instead of having just steroids. Thank you very much.